Ladies and gentlemen, thank you for the opportunity to discuss COVID-19 related anxiety in men with localized prostate cancer at tertiary hospitals in Cape Town, South Africa. My name is Irusen, and I'm based in the Department of Urology at Stellenbosch University. It has been well documented that pandemics can cause anxiety, as was seen during the H1N1 flu. At the onset of the COVID-19 pandemic, the World Health Organization raised concerns about the impact of anxiety in older people. The data for the study was obtained from a larger prospective multi-centered observational study examining anxiety, depression, and health-related quality of life in men undergoing curative treatments for localized prostate cancer, DARCAP. Participants were interviewed with validated questionnaires pre-treatment, in other words pre-COVID, and every 12 weeks for the first year. As anxiety is a primary endpoint for the DARCAP study, it was necessary to measure the effect of COVID-related anxiety on state anxiety for these participants. The South African Stress and Health Group SASH estimated the prevalence of anxiety at 16% and for older individuals at 11.3%. Anxiety during the COVID-19 pandemic was measured by Huang and colleagues and found that younger individuals were at highest risk for anxiety than older individuals. A Spanish study also concluded that anxiety was not seen in older individuals. A concern that was highlighted was the effect of COVID-19 anxiety on older people with comorbidities. Remusi and colleagues published an article in The Lancet which said that 2/3 of older people in Italy with comorbidities died from COVID-19. Hussein's group found that individuals with comorbidity had more mental dysfunction. We hypothesized that there would be a positive correlation between COVID-19 related anxiety and general state anxiety. Our second hypothesis was that COVID-19 anxiety would be negatively correlated with resilience and social support. Our sample size included 60 participants from the DARCAP study, the main prospective observational study, and included men that underwent radical prostatectomy, external beam radiotherapy, and brachytherapy for localized prostate cancer. Assessments were done pre-treatment and 12 weekly for the first year. The participating centers were the Departments of Urology and Radiation Oncology at both Stellenbosch University and the University of Cape Town. Assessments were done between July and September 2020 at the height of the pandemic. Validated questionnaires with the Likert scale was used. The COVID-19 scale, the CAS questionnaire, was administered once along with a set of DARCAP questionnaires which were part of the scheduled visits. 4 questionnaires were used for this study. The CAS, the Coronavirus Anxiety Scale. This is a 5-item scale which was used to denote dysfunctional anxiety. A cutoff for the study was used as greater than or equal to 9. The second questionnaire was a STAY-S, which is used to measure an individual's current state of anxiety. The cutoff here was 40, which was used to detect clinically significant symptoms of anxiety. The third questionnaire was the MSPSS, or the Multidimensional Scale of Perceived Social Support. This was used to measure the support an individual obtained from family, friends, and their significant partner. The 12 items were grouped in subscales of family, friends, and significant others. And the last scale was a Connor-Davidson Resilience Scale, the CD-RISC, which measures resilience, hardiness, control, commitment, and stress. Higher scores indicating greater resilience. And then, of course, we use demographic data. The demographic and clinical data. We found the mean age to be 63.2 years, with a range of between 51 and 73 years. We also found that 44% were pensioners, 33% employed. In terms of clinical features, a quarter had heart disease, almost 2/3 were hypertensive, and 1/5 diabetic, all risk factors for severe COVID. More than 2/3 of the cohort indicated that they had a history of smoking. In terms of the results, we found no correlation was observed between the demographic variables and the CAS score, except for the monthly income. Surprisingly, the CAS score was low at 0.95. Only 3% of the group scored greater than or equal to 9. The mean change in state anxiety score pre-COVID to during COVID was 4.9, which was statistically significant. There was a positive correlation between knowing family and friends that had COVID and a higher CAS score. We also found no correlation was observed between the CAS score and the STAY-S and the CD risk and MS-PSS. We also found a negative correlation between the CD risk and the STAY-S at baseline and during COVID. STAY-S showed a significant decrease between pre-COVID-19 to during COVID-19. We also observed a moderate statistically negative correlation between the STAY-S and CD risk during COVID-19. There was also a weak positive correlation between the CD risk and MS-PSS. There was a significant reduction in state anxiety pre-COVID to during COVID. We postulate that the drop in anxiety may have been due to that all patients had received their treatments for prostate cancer. Similar results were seen in a meta-analysis done by Sam Watt and colleagues. We found no correlation between the STAY-S and COVID-19 anxiety, despite most patients knowing of family and friends with the virus. Similar outcomes were observed in other studies. Despite comorbidities, patients did not exhibit significant COVID-related anxiety. We also found that men who knew of family and friends that had contracted COVID-19 had significantly higher scores. We also found a negative correlation between CD risk and STAY-S. We suspect that CD risk may have had a buffering effect on anxiety. CD risk was significantly correlated to the MS-PSS, suggesting support from family and friends that contributed positively to resilience. The limitations of the study was a cross-sectional nature of the study, as directionality could not be determined. In addition, this was a small sample size, and visual clues may have been lost during telephonic interviews. So in conclusion, ladies and gentlemen, we'd like to say that COVID-19 anxiety in men with localized prostate cancer undergoing prostate cancer treatments was negligible, and we did not show any correlation between state anxiety, resilience, or social support to COVID-19 anxiety. In terms of future directions, a qualitative study to understand the low levels of anxiety seen might be very useful, and validation of the CAS questionnaire in men with localized prostate cancer might also be helpful. Thank you very much, ladies and gentlemen, for your time.